The first step of the obstetric abdominal exam is visual inspection. Before you ever place your hands on the patient, you must look carefully. A thorough visual assessment provides valuable information and often guides the rest of the examination. Your eyes frequently identify important findings before your hands ever touch the abdomen. Proper observation helps determine where to focus your examination and may reveal abnormalities that require immediate attention. The first thing to assess is the overall shape of the pregnant abdomen. In a normal pregnancy, the abdomen should have a smooth, rounded, dome-like appearance with a symmetrical anterior protrusion. The contour should appear balanced from side to side. If the abdomen appears noticeably lopsided, with one side bulging significantly more than the other, or if the entire uterus seems to lean predominantly toward one side, this finding should not be ignored. Such asymmetry is considered abnormal and may indicate fetal malposition, a uterine anomaly, or, in rare circumstances, the presence of an abdominal mass. Careful observation of abdominal symmetry provides important clues about what may be occurring inside the uterus and helps guide further assessment. The second observation involves identifying abnormal abdominal distension during the first trimester. Gestational age and abdominal size should generally correlate. If a patient reports that she is approximately 8 weeks pregnant, but her abdomen appears similar in size to that of a woman who is several months further along in pregnancy, this discrepancy is concerning. Such excessive enlargement is not considered a normal finding. Significant abdominal distension in early pregnancy raises suspicion for serious underlying conditions. Possible explanations include bleeding, inflammation, molar pregnancy, or multifetal gestation. These findings should immediately increase clinical concern. When visual inspection reveals abdominal enlargement that is disproportionate to the reported gestational age, providers should elevate their level of suspicion and recognize that transport priority may need to increase accordingly. The third component of inspection is the identification of surgical scars. Every scar represents a previous surgical event and provides important historical information. In the pregnant patient, abdominal scars can offer insight into prior obstetric procedures. A large horizontal scar located low on the abdomen often indicates a previous cesarean section. The most common type is the Pfannenstiel scar, a low transverse incision frequently referred to as the bikini line incision. This approach has become the modern standard for cesarean delivery. In contrast, a vertical midline scar may suggest a classical cesarean section or an emergency surgical procedure performed in the past. Recognizing these scars is important because prior uterine surgery has implications for future pregnancy management. Knowledge of previous cesarean incisions can influence concerns regarding uterine rupture risk and provides critical information that should be communicated during hospital handoff. The fourth finding to observe is the Linea Nigra. This is a vertical line that runs along the midline of the abdomen from the pubic bone upward. Depending on the patient and the stage of pregnancy, it may appear faint or highly prominent. As pregnancy progresses, the line often becomes darker and easier to identify. Although its exact purpose is not completely understood, one commonly discussed theory suggests that it may function as a visual guide for the newborn during the breast crawl. The breast crawl is a remarkable phenomenon observed immediately after birth. When a newborn is placed on the mother's abdomen, the infant may instinctively move toward the breast without assistance. Using coordinated movements, the newborn can slowly crawl, locate the breast, and achieve a latch independently. This behavior is considered one of the most fascinating natural newborn responses. The Linea Nigra is thought by some to potentially assist in this process by providing a visual pathway from the lower abdomen toward the breast. Whether faint or prominent, its presence is a normal finding during pregnancy and should be recognized during visual inspection. The fifth and final component of abdominal inspection is the search for traumatic findings. Providers must carefully examine the abdomen for abrasions, ecchymosis, active bleeding, lacerations, stab wounds, penetrating trauma, and gunshot wounds. Any evidence of injury can significantly alter patient management. Trauma assessment remains essential regardless of gestational age. In pregnant trauma patients, the principle remains clear. Maternal stabilization is fetal stabilization. The well-being of the fetus depends on the well-being of the mother. However, providers cannot address injuries that they fail to identify. For that reason, proper exposure and thorough visual inspection are critical. A careful examination ensures that traumatic findings are recognized promptly and that appropriate interventions can begin without delay. Visual inspection is therefore far more than a simple first glance. It is a structured assessment that evaluates abdominal shape, identifies abnormal distension, recognizes surgical history through scars, notes the presence of the Linea Nigra, and detects evidence of trauma. By taking the time to look carefully before touching the patient, providers gather essential information that guides the remainder of the obstetric abdominal examination and supports safe clinical decision-making.